today's session. Okay, can you hear me and can you see the screen?
Yes, Dr. Manas.
Yes.
Okay.
Yes.
So, on behalf of PHO chapter, before we start today's session, I just wanted to, pay respects to Professor Dr. Praveen Sopti, a very important and very vital member of our pediatric hematology oncology chapter. She has contributed immensely to our chapter. She has contributed immensely to the lives of children with thalassemia in Ludhiana. And I would say that, anywhere in North and anywhere in the country, in fact, when we talk of thalassemia, Dr. Sopti's name would definitely feature into the list of stalwarts who made such a huge impact to the life of children with thalassemia. So she was professor and head. She was professor and head of the the Dayanand Medical College, Ludhiana, and then also at CMC Ludhiana, and then she was the medical director of Guru Tegh Bahadur Hospital in Ludhiana. She had a very illustrious career when we talk of her achievements in pediatric hematology, oncology, especially thalassemia. She is no more with us, and the PHO chapter members, it's a big loss for all of us. So in her memory, I request all of you to just observe silence for 1 minute. And subsequent to that, we will start our academic session. So we all miss you, Praveen Madam, and our condolences to your family and all the well-wishers and to the entire PHO community. Vasudev, I'll request you to now take over the session and introduce our moderator and speakers, please.
So, good evening, everyone, and thank you for joining for this session, that is the PHO online teaching program. And for this session, we have kept the topic of contemporary management of medulloblastoma, the Indian perspective. Medulloblastomas, as you all know, that it is one of the commonest brain tumors that we see in children. And to throw light on this topic, we have eminent speakers who have joined us. And the moderator for this session is Dr. Vikramjit Kanwar, who is Professor Emeritus Pediatrics, Albany Medical College, New York, and Chief of Pediatric Oncology, Homi Bhabha Cancer Hospital, Varanasi. I would request Dr. Vikramjit to kindly introduce the speakers. Dr. Chitra Madam would go first, following which Dr. Maya Prasad will be presenting on the non-infantile medulloblastoma management, and then Dr. Ramya on the management of infantile medulloblastoma.
So greetings to the whole audience. So we're very happy to have three very talented speakers with us this evening. I wasn't given a formal introduction, but I think you've done a good job, Vasudev, And I think many people who already know Dr. Chitra, our ICMR emeritus scientist, who's also former dean of research, former professor of neuropathology, former head of Department of Pathology, and has a long history in neuro-oncology in India. So we look forward to hearing her talk. We'll go forward from there. Dr. Chitra, please.
Good evening to one and all. At the outset, I would like to thank the organizers, especially Dr. Manas and Dr. Bhatt, for having given me this opportunity to present my talk on pathology and molecular aspects of medulloblastomas, applicability in our country. Now, CNS embryonal tumors are a heterogeneous group of malignant tumors which mainly occur in children, are all CNS WHO grade 4. The earlier term used, as you are all aware, is CNS PNETs, but now since 2016, this term is obsolete. In the pediatric population, as per the CV Trust data, embryonal tumors constitute about 15% of all pediatric CNS tumors. You all know that the WHO CNS-5 was released in 2021, where embryonal tumors have been classified as 1, medulloblastoma, and 2 other CNS embryonal tumors, which include atypical teratoid rhabdoid tumor or ATRT, embryonal tumor with multi-layered rosettes, ETMR, 2 new entities, CNS neuroblastoma, FOXR2 activated, and CNS tumor with BCOR internal tandem duplication. A provisional entity, cribriform neuroepithelial tumor, to which no grade has been assigned. Now, among the CNS embryonal tumors, the commonest, as we all know, is medulloblastoma, constituting 20 to 25% of all CNS tumors with a peak age of 5 to 7 years. The location is always in the cerebellum, more commonly in the vermis, but can be hemispheric, especially in adults. Now, again, the 21 classification of medulloblastomas is similar to 2016 with a few minor changes. So we have the medulloblastoma histologically defined and the medulloblastoma molecularly defined, which is further subdivided into the medulloblastoma Wnt activated, SHH activated and TP53 mutant, SHH activated and P53 wild type. And then we have the non-Wnt, non-SHH activated, which has 2 groups, group 3 and group 4. Now, coming to the histologically defined medulloblastomas, we know from several years now, several decades, that the histological types of medulloblastoma are the classic desmoplastic nodular, the MBEN, which is a medulloblastoma with extensive nodularity, and the large cell anaplastic variant. There is some difference in the age distribution of occurrence of these different histological types. Classic occurs over a wide age range with 60 to 70% in children. Desmoplastic shows a bimodal age distribution with peaks in young children and adults. MBN is always in children less than 3 years old, and LCA again is over a wide age range. These are some of the histological pictures. Classic is the typical blue cell tumor with 40% showing the Homer-right rosettes. Desmoplastic are the nodules separated by the internodular reticulin-rich stroma. MBN, where you have the streaming pattern of neurocytic cells in a fibrillary background with not so well-defined nodular pattern. And the large cell anaplastic, as the name indicates, very large anaplastic cells with high mitotic rate, apoptosis, and the nuclear molding as seen in this picture. Now, histologically, the approach to diagnosis is not very difficult, and based on the H&E stain, along with the clinical features and the radiology, one can make a diagnosis of medulloblastoma. Most pathologists with some experience in neuropathology would be able to do it. But one thing you have to insist upon is the reticulin stain to identify the nodular variants of medulloblastoma. And if IHC is available as synapto, because these tumors are diffusely positive for synapto and a high MIB1 labeling index. In case there are differential diagnoses like ATRTs or ETMRs, other embryonal tumors, then one needs to do other types of immunohistochemical stains to rule out the other embryonal tumors and undifferentiated high-grade gliomas. Now, is there an importance of looking at the histological type? And as I go through, you will, what I have tried to highlight is that histology is still very important, and you may get a lot of answers from histology itself if you do not have the molecular stratification alone, at least in resource limited countries. So as you can see, the best prognosis is with MBEN, which generally occurs in children below 3 years. And the worst prognosis, always a high-risk category, is the large cell anaplastic medulloblastoma. Now, classic can be of different molecular subtypes and therefore has a variable outcome depending on the molecular subtype. The desmoplastic MB has an excellent outcome in infants and younger children, but not so much in older children and adults. So the histological variant does give some amount of risk stratification of medulloblastomas and has prognostic importance, which was shown as long back by Marcel Kuhl in 2012 and still holds true. Now, coming to the molecularly defined medulloblastomas, they have been divided into these 6 types, and there are further subtypes which I'm not going to deal with because I do not know how much clinical importance there is. Very difficult to subtype further. But this is important because there are differences in demographics. The Wnt activated, the p53 mutant generally occurs in children. The p53 wild type SHH in infancy and adulthood, group 3 again in infancy and childhood, whereas the group 4 occurs across all age groups. Differences in the morphology. Classic, as you can see, can occur over both Wnt activated, group non-Wnt, non-SHH group 3 and group 4. Large cell anaplastic is mainly in the p53 mutant SHH and the group 3, and desmoplastic nodular is almost always the SHH type and largely the p53 wild type. And copy number alteration, which is of prognostic significance, is the amplification of CMYC and NMYC. CMYC is characteristic of group 3 tumors, whereas MYC-N can be seen both in the p53 mutant SHH as well as in group 4 tumors. p53 mutation, of course, is classical in the SHH TP53 mutant and CTNNB1 mutation in the Wnt activated tumors. Now, these differences are important, yes, in demography and genetic alterations in the histopathological types. But what is most important and therefore which has made this classification very popular is the relationship to prognosis. Thus, Wnt medulloblastomas have an excellent prognosis, most favorable outcome, especially in patients less than 16 years. They have an excellent survival independent of the protocol that they are being treated with. But not so when it is more than 16 years, where it goes into the more higher category of risk. So de-escalation of therapy, as you know, there are several clinical trials going on for the Wnt group. Coming to the poor prognosis, the next end of the spectrum, the p53 mutant has a definitely poor prognosis, and the non-Wnt, non-SHH group 3 tumors have a very poor outcome, especially those associated with the CMYC amplification. The p53 wild type and the group 4 have an intermediate prognosis. And the MYC-N amplification, which I spoke about, seems to have a different prognostic connotation in p53 wild type, where it has a worse prognosis, whereas in group 4, it does not carry so much of a prognostic outcome. But important to remember that the molecularly defined has a definite correlation and therefore with prognosis, and therefore it's very important that we recognize the best prognosis group, the Wnt, and the worst prognosis group, that is the p53 mutant SHH and the group 3 non-Wnt, non-SHH, so that the treatment, management, and the outcome can be explained to the patient accordingly. Now, we are all familiar, coming to the stratification systems which are available. We all know that this is the most common one being used since the mid-90s, the Shank staging system of average risk and high risk based on the age, residual tumor, and evidence of metastasis. Until now, the treatment has been based totally on the Shank staging system with prognostic differences. But the molecular subgrouping, because of its prognostic implication, has become very important to ascertain for prognostication and risk stratification also, and as well as for treatment, planning treatment and targeted therapies. So the SIOP 2023 has released a document, and we divide now into the low risk or the favorable risk, the standard risk, where you have more than 75% 5-year survival, low risk has more than 90% 5-year survival, and the high risk or very high risk, which has less than 40% 5-year survival rates. Now, the SIOP guidelines would be available to you all, where the risk groups for children aged 3 to 5 years older and over have been put out as low risk, standard risk, and high risk. Similarly, for risk groups for children less than 3 to 5 years also have been put up as low risk, standard risk, and high risk. These will be available to you, which is in combination of molecular histology, residual, and metastatic disease, a combination of the clinical stratification and the molecular stratification. But I will, for purposes of today's lecture, try to make it simplified for you to understand how would you approach to do these stratification systems and how they correlate in a simpler, in a more simplified manner, which will possibly be useful in routine practice. So if I can make the clinical stratification correlation with molecular group, histological type, and age, so we have the WINT. WINTs are generally histologically the classic morphology occurring in older children and adults. They are low risk, especially if it is less than 16 years, but standard and high risk if more than 16 years. The other, the next molecular group is the SHH-P53 wild type. In this, the morphology in children less than 3 years can be MBEN, which is always a low-risk tumor. The WINT in less than 16 years is always a low-risk tumor. MBEN in children less than 3 years is always a low-risk tumor. Then one can have the desmoplastic nodular, which occurs, as I told you, at the bimodal age range of infants and adults. This is low risk in infants and young children, less than 3 to 5 years, but standard to low risk in older children and adults. Classic morphology for an SHH-P53 wild type is very rare. Then we have the SHH-P53 mutant, which may show MECAN amplification sometimes. The histology is generally of an LCA, but rarely can be desmoplastic or classic. This occurs in children and teenagers. It is always a high-risk tumor. The group 3 non-WINT non-SHH can also be morphologically either classic or an LCA tumor. Occurs more in infants, about 40 to 45% are in infants, and also in children. They are always high-risk tumors. And group 4, which can occur over all age groups and generally classic in its morphology, are standard to high risk. So you can see here that classic occurs over a wide molecular range. You can have WINT, classic can be WINT, it can be P53 mutant, it can be group 3, it can be group 4, and rarely P53 wild type. And it can occur over all age ranges, and the risk will depend upon the molecular type. So therefore, this is a simple way of remembering the low-risk tumors and the high-risk tumors in correlation with histology and the molecular group. So let me next go on to what are the different ways in which we can identify the molecular group? Histology will definitely come, but how can we identify the molecular group in various ways before we go on to the actual molecular tools to molecular subgrouping? Now, these are some leads. They are not absolute, but these are some leads which will help you clinically along with the histology, because obviously you will have a histological diagnosis of the type of medulloblastoma. So if we put the clinical and the histological features defined, again, a sort of a simplified table. If it is an infant, if you have an infant and the histology is MBEN or a desmoplastic nodular, most likely it would be an SHH-P53 wild type and will be a low risk tumor. But if you have a classic or an LCA tumor in an infant, most likely it will be a group 3 tumor with MYC amplification and will be a high risk tumor. So this is between clinical and histology. If you do not have the molecular grouping, you can think that if you have an LCA tumor in an infant, most likely it would be a group 3 and a high risk tumor. And LCA is anyway a high risk tumor. But if you have a classic morphology, but in an infant, you will have to do molecular grouping in order to ascertain that this is a group 3 tumor. Now, in children, you can have the classic morphology with the Wnt being most common, which is low risk tumor below 6 years. You can have group 4 non-Wnt, non-SHH, which is standard high risk. The group 3 is extremely rare. Then you can have LCA tumors in children, which are generally SHH-P53 mutant, again, high-risk tumors. In adults, the commonest is desmoplastic hemispheric, which is generally P53 SHH, standard low risk. LCAs, group 3 are again rare, but you can have classic of all types. Again, Wnt is rare, but in adults, the group 4 is common, standard, high risk, more than 16 years. So by age and histological type, you can roughly make a molecular group, think of the molecular group and the risk stratification accordingly. Radiology, of course, has come a long way, and I do not have to tell clinicians about the radiological features, which are very apparent between classic, desmoplastic, which are often laterally located, and the MBEN, which has the typical grape-like appearance. But what has come up in recent years is radiogenomics of medulloblastoma, where the radiology is being looked at to give the molecular subtypes. And one very important paper was published from and Dr. Tejpal Gupta, and there have been several publications since then, but I'll just go into one or two important points about these, and you can go into details. The Wnt is the midline location, but commonly extends to the cerebellopontine angle and the cistern, and typically appears close to the brainstem, and there may be an infiltration of the brainstem. SHH, as I told you, is generally lateralized location. Midline location can occur in infants and young children, no involvement of the dorsal brainstem. Nodularity can be recognized. The group 3 is again midline location with a fluffy type of enhancement. Metastatic disease is often laminar or sugar coating pattern of the disease. Group 4, midline location again, but often closely related and abuts on the dorsal brainstem, and the metastatic disease shows the nodular features. So you can go into further details as clinicians and discussing the radiology with your neuroradiologist may help you, give you some direction based on these features between the different molecular subtypes. And Dr. Jalali at Apollo uses this very often for making a clinico-radiological correlation before the actual histopathology and the molecular subtype comes out to guide him regarding what may be the molecular subtype. So all of you should read this article. The next way is for immunohistochemistry, which is very pathologist friendly. And you just have to do what we have published and what is now 3 to 4 antibodies, the GAB1, beta-catenin, and the YAP1. You can add filament if you want. There are different combinations which have been proposed, but beta-catenin is for the Wnt tumors, GAB1 is for the SHH tumors, and YAP and filament are negative in both SHH and Wnt tumors. So this becomes very important and very simple, that 3-panel immunohistochemistry can give you the molecular subtype. But it gives you only 3 subtypes: Wnt, SHH, non-Wnt, and non-SHH. It does not give you group 3 and group 4. But what I would like to add here is a P53 IHC, especially if it is a nodular medulloblastoma, that is a desmoplastic medulloblastoma of the SHH type. Please do add P53 IHC in those cases where it is, especially in infants and children, to add a P53 and IHC to the desmoplastic nodular medulloblastomas, and I will tell you why. Now, from immunohistochemistry, we graduate. If you have further facilities, you can supplement with fluorescence in situ hybridization, FISH, and sequencing. Now, what are those which are generally highly recommended or optional? For the non-Wnt, non-SHH, this MYC amplification is highly recommended because that gives the group 3 tumor, which has the worst prognosis, and there is no surrogate IHC for it. MYC amplification is also highly recommended because it's seen in non-Wnt, non-SHH group 4 tumors and SHH P53 mutant tumors associated with a poor prognosis. But MYC is definitely highly recommended. If you ask me for one FISH, I will say it is MYC amplification. For Wnt tumors, if there is a problem with the IHC markers, then, and they are very equivocal, but because it is the best prognosis tumor, you can add a Sanger sequencing tool of CTNNB1 mutation or a FISH with monosomy 6, but it remains optional depending upon your IHC panel. The P53 mutation is staining is positive on IHC, then you have to do a P53 mutation. Otherwise, it is optional in all the other types of medulloblastoma. So this is what we published in the ISNO guidelines way back in 2017, that depending upon the availability of resources and affordability, you can do only the histology or supplemented with IHC with the 3 antibody panel. Next step, you can go to FISH and Sanger sequencing. In the higher ones, nanostring or the gene expression profiling, and the gold standard, as you all know, is DNA methylation profiling. So this will depend upon your resources and affordability. And in our country, DNA methylation profiling may be very difficult for 1 or 2 cases that we get, that each one of you get to see. So maybe the IHC and supplemented with FISH and Sanger sequencing will be very useful. And again, the last 2 slides, I will show you in a very practical manner what you can do for your routine applications and management of your patient. So this is a flow chart. So of course you will operate on the patient, and it would go for the histology, and you would get classic, desmoplastic, MBEN, and LCS. If you have IHC, you do the 3 marker panel along with P53, which tells you it is Wnt, SHH, or non-Wnt, non-SHH. If the P53 IHC is positive, you will go ahead and do a P53 mutation. If it is a P53 mutant, then you give it's mutant positive, then you call it P53 mutant SHH or a wild type. For a non-Wnt, non-SHH, I would recommend definitely a c-MYC amplification. If the c-MYC amplification is present, it will be group 3. But if it is absent, it's more likely to be group 4. You can supplement with a MYC amplification. So as a screening test, so you have Wnt, where you can do CTNNB1 mutation optional. You can here P53 IHC and P53 mutation if required, but as a screening test, it is found that P53 IHC itself is 100% sensitive and 83% specific for a P53 mutation. So as a screening tool, do P53 IHC in all SHH tumors and MYC amplification in non-WNT, non-SHH tumors to identify the worst prognosis group, that is the group 3. If you do not have enough support for your molecular, if it is a classic, you have to, because it can be of different molecular subgroups, it is mandatory that you have to do the molecular typing if you get a histology report of a classic medulloblastoma. But if you get of MBEN, of a DN in infants and adults, they can be optional because most likely they are SHH P53 wild type, which are low risk tumor. But if you have this desmoplastic in children and teenagers, it can be a P53 mutant type and therefore mandatory to P53 IHC and mutation if required. If it is LCA again and you do not have moleculars, LCA is always high risk. So if you do not have tools for MYC, but an LCA morphology, go ahead and put it in the high risk category. So this can be a practical approach just with histology, that the mandatory molecular typing, you go for all classic. I agree that classic is the most common type and therefore it will be essential to do at least the immunohistochemistry and some of the molecular types. But if you get MBEN and DN in infants and adults, then just it can be optional, and LCA is always high risk morphology. You can put it as high risk even if you do not have the tools for doing the molecular typing. So this is a sort of a practical approach that you can do for medulloblastomas. And the last to remember is therefore to reinforce that low risk is MBN histology, desmoplastic histology in infants and young children less than 3 to 5 years, WNT in less than 16 years, and the SHH P53 wild type again in infants and young children. High risk is always LCM or histology. Non-WNT, non-SHH, MYC amplified, which is group 3, and SHH P53 mutant with or without MYC amplification, which is also high risk. The others, which are a little on the borderline and which can be standard or low risk, putting together many other factors, is the desmoplastic histology and the SHH P53 wild type in older children and adults, and the standard high risk in the WNT or more than 16 years and non-WNT, non-SHH group 4. So this is a very simple way of looking at the risk stratification. So the last two slides simplify and tell you applicability in our country depending upon your resources and to do the risk stratification and the management accordingly. The costs which you all are aware of because of the DNA methylation, the range can, especially in FFPs, can range from 60 to 65, and they do not do a single specimen, they want a full batch. NGS is about 15 to 35,000, and whereas IHC, as you know, is the cheapest, 3,000 to 5,000, and now FISH, I think you can get by about 8,000, and Sanger sequencing by 4 to 6,000, and their turnaround times are also shorter. Hence, to conclude, I would like to emphasize that pediatric CNS tumors continue to remain a challenge, both in terms of diagnosis and treatment and management, and the long-term effects of the management and the treatment. So for tumors like medulloblastomas, where there has been great advances in molecular techniques and molecular biology, I have tried to simplify how in resource-limited countries like ours, we strike the balance using a combination of clinical features, histology, radiological features, radiogenomics, and the advanced molecular tools. So I hope this will be a good practical guide for you all. And I'm sorry if I've exceeded the time, but thank you all for a very patient hearing.
Thank you, Dr. Chitra, for a wonderful presentation. I think all of us enjoyed it. The questions are being held to the end in the interest of time. So please put them in the chat box. I believe my colleague, Dr. Maya Prasad, professor in pediatric oncology from TMH, will be the next speaker and will be presenting children with medulloblastoma, leaving Dr. Ramya, who will be the last speaker to pick up the tougher cohort of infants. So Maya, please go ahead, all yours.
Yes, good evening, everyone. Vasu, how audible am I?
All good.
Yeah, thanks. So thank you, Dr. Chitra, ma'am. I think it was a wonderful talk, and thank you very much. So as Dr. Vic mentioned, I will be speaking about the treatment of older children, that is about 5 years of age with medulloblastoma, and quickly to go through what are the diagnostic evaluations to be done in a child who comes with medulloblastoma. So clinical evaluation in all cases, hostile evaluation in select cases, and of course, diagnostic imaging, very, very important. Generally, most patients get a CT scan first off because it's easy to do and also more easily available. But MRI is the preferred and recommended first-line imaging for multiple reasons. And there are also recommended MRI protocols which are to be used specifically for medulloblastoma. Once we have a histopathological diagnosis of medulloblastoma, we need to do CSF studies to look for staging. And although metastases outside of the CNS are very rare, if there are any signs suggestive of those, we'll need to evaluate for those. And then the 5% of children who have genetic predisposition syndromes, there are specific indications for genetic testing, and we need to do those as well. So I think Madam has covered a large part of the risk stratification, but the key risk stratification, the key parameters used in risk stratification are stage and the extent of the CNS disease, which is assessed by the Chang staging. M0 is, of course, when there's no evidence of metastasis in the CNS, and M1 to M4 reflect various stages of CNS metastasis. The age of diagnosis is an important prognostic factor, mainly because of the difference in biology, especially in infants, but also because of certain treatment restrictions that we may have in this age group. Ramya will be speaking all about that. Another important factor we looked at is the amount of tumor that's left behind after resection. Generally, that's assessed. This is assessed by a CT scan or MRI, which is done after 24 to 48 hours of surgery, or sometimes we may need to assess it only on an MRI, which is done 2 to 3 weeks later. And although older studies showed that a residual disease of more than 1.5 centimeter was prognostic, later studies have only found a modest benefit of this factor, prognostic factor. So that's probably because, in most of these retrospective studies, patients were already considered as high risk as a consequence of their post-operative residual disease and received high-risk treatment anyway. So that blunted the importance of it as a prognostic marker. Madam has beautifully described the impact of histology as well as the impact of molecular groups. And also, she's also described, which I will be describing later, how molecular characteristics are now being incorporated into risk stratified treatment. So this is the summary of the risk stratification that's used to determine the treatment of a child with medulloblastoma. And if you take off the first row, which is age, then in older children, it leaves us with both these criteria of no residual disease and no metastasis to classify the child as being average risk, and none of these adverse factors should be present. Also very important to remember, in our country where there is such a heterogeneity of health systems, it's not uncommon to find children who have been partially treated or completely staged. So it's more prudent to treat these children as high risk. Once we find a child with a posterior fossa lesion on imaging, first we need to do the emergency management and make sure that all the raised ICP features are under control, and then proceed to a maximum safe resection. The timing of the surgery depends, the urgency of the surgery will depend on the clinical condition of the child. And Then once we have the diagnosis, we need to go ahead with staging, and that should be done preferably within the first 3 weeks. Once risk stratification is done, radiation needs to be started again within the first 4 weeks if possible. Radiation is preferably done within a span of 50 days. So the duration of radiation, which exceeds 50 days, is found to lead to inferior outcomes. Once radiation is done, we need to start chemotherapy after a period of 4 to 6 weeks, again, preferably 4 weeks. So surgery in medulloblastoma really relies on the principle of maximal safe resection. So because it may involve many crucial structures of the brain, only safe resection needs to be done, causing minimum morbidity and neurological sequelae. There is no role for heroic surgeries here, especially in cases of wind medulloblastoma, which are very close to the brainstem, but also are extremely chemosensitive. So you don't really need to take out every little bit of tumor tissue. Also, because generally these tumors in the posterior fossa block the fourth ventricle, the removal of the tumor itself helps unblock the CSF pathway and resolve hydrocephalus if it was there. And amongst the postoperative complications, something that's very specific to posterior fossa tumors is cerebellar mutism or the posterior fossa syndrome, which is quite specific for this. Adjuvant radiation therapy is one of the key treatment modalities in children with medulloblastoma, and something that's been studied so much because of the potential impact on the late toxicities. So here comes one of the main importance of risk stratification, because both high risk and average risk receive different kinds of radiation. Craniosspinal as well as local tumor radiation are given, and it is to ensure that the tumor receives 54 to 55 rays of radiation. So when you treat a child with high-risk disease, the child needs to receive full dose craniosspinal irradiation, which is 36 rays, and the remaining dose to come to a total of 54 needs to be given only as a boost to the tumor. So in high-risk disease, we give a whole posterior fossa. If there are gross spinal disease as well, we need to boost those diseases, those sites of disease as well. In average risk medulloblastoma, we give reduced dose craniosspinal irradiation, which is 23.4 grays, and the tumor bed boost that is higher because it has to finally total 54 to 55. So prior to the advent of multi-agent chemotherapy and its role, recognition of its role in medulloblastoma, most children were treated only with full dose craniosspinal irradiation, and it did actually cure a substantial proportion of them, especially if they were average risk disease. But then we also know that there could be a substantial amount of morbidity both in the short and long term as a result of this high dose whole brain radiation to children, and mainly in the form of neurocognitive and endocrine toxicities. So that most of these studies have looked at trying to reduce either the dose or the volume of radiation to the brain. So what has been successful is the reduction in the CSI dose to 23.4 gray with the addition of chemotherapy in average risk medulloblastoma, and also the decrease in the volume of radiation that's received in average risk medulloblastoma from the entire posterior fossa. We can now just irradiate the tumor bed. And this was in a seminal study from COG, where it found that we could safely decrease the boost volume in average risk medulloblastoma. The other very important study in this regard was a couple of studies by Packer et al., again by the COG, where it was found that children with average risk medulloblastoma had improved outcomes when they were given reduced dose CSI followed by 8 cycles of combination chemotherapy. So this study is also an important study chemotherapy-wise, and we'll come to that later. There have also been various other technical kind of modifications and which have tried to look at reducing toxicity and or improving efficacy. So one of these is the use of hyperfractionated radiation, which has been found to decrease the toxicity. and the addition of concurrent chemotherapy to high-risk disease during radiation, which has been used in metastatic disease. But I think probably the hero of this entire slide is proton beam radiation. And I really don't think this talk will be enough to talk about proton beam, which has been substantially found to reduce some toxicities in children with medulloblastoma as compared to photon radiotherapy. Although the efficacy in both cases is apparent. So in metastatic medulloblastoma, a couple of studies from the COG have looked at the addition of carboplatin during craniospinal irradiation. Firstly, there was a phase 1-2 study which actually looked at the feasibility, and then a phase 3 randomized study which was reported recently, and it found that in group 3 disease, the addition of concurrent carboplatin improved the event-free survival, and this was especially true in group 3 metastatic disease. We've also been using this at our center, and I think a lot of centers in India now use concurrent carboplatin. What is not completely clear is the role of concurrent vincristine, which still is used in many, has been used and still is used in COG studies, but not used in many other studies. So we really don't know what the role of concurrent vincristine is. So Madam has talked about how wind medulloblastomas are a highly favorable group of medulloblastoma, and that there are several features which contribute to this. One of it is that it is extremely porous and highly chemosensitive. So that has allowed researchers to reduce the dose of craniospinal irradiation in wind medulloblastomas. So multiple studies are now looking at the reduction of craniospinal irradiation dose between 18 and 15 grays of CSI. But a few studies that looked at complete omission of radiation or giving only focal radiation instead of CSI have actually failed. So that is not a good strategy in wind medulloblastoma. Chemotherapy is, of course, very important in children with medulloblastoma, although in some adults it may actually be omitted. And what we know from the many studies that have been done in average risk medulloblastoma is that, of course, we can reduce the dose of CSI if we add chemotherapy to it. And in average risk medulloblastoma, the sequence has to be surgery, radiation, and chemotherapy. So there's no role for giving chemotherapy prior to radiation. This has been found in average risk medulloblastoma. And these are the combination of drugs, cisplatin, cyclophosphamide, lomustine, and vincristine are the drugs which are used in most cases of average risk medulloblastoma. And there really hasn't been a role of high-dose chemotherapy and autologous stem cell rescue in this. In high-risk medulloblastoma, again, European protocols like the SIOP PNET protocol has looked at giving pre-radiation chemotherapy. So surgery followed by sandwich chemotherapy, followed by radiation, followed by maintenance chemotherapy. Although that's not, again, a preferred kind of treatment strategy, certain European protocols still use it. And there are protocols which also look at the use of high-dose chemotherapy in high-risk medulloblastoma. So coming back to Packer's study, there have been a couple of publications because there were two or three studies, and the phase 3 study of reduced dose CSI followed by adjuvant chemotherapy looked at the comparison of 2 different types of chemotherapy. So 8 cycles of both these chemotherapy regimes were used, and both of these regimes, which were either lomustine or cisplatin in combination with cyclophosphamide and vincristine. So both of these cycles were found to be equally effective, but the cisplatin dose, the cumulative cisplatin dose of 8 cycles of cisplatin was actually a whopping high dose of 600 mg per meter square, which resulted in a very high dose of a very high rate of autotoxicity. So subsequent COG studies have reduced the cisplatin dose. So there are only 3 cycles of cisplatin, and there are 5 cycles of A. So 5 cycles of A and 3 cycles of B, given as AAB, AAB. Maintaining the efficacy. There has been a series of studies from the Senju group, and there's SJMB9603 and SJMB12, which looked at, again, risk stratified radiation, followed by 4 cycles of chemotherapy which are given in a highly intensive fashion. So monthly, 4 weekly cycles of four weekly cycles are given. And in order to maintain the chemotherapy dose intensity, peripheral blood stem cell infusions were also given. So this is the autologous stem cell rescue, which is used in the SJMB trials. So actually, there's only 4 months of chemotherapy, but a large cumulative dose of chemotherapy is delivered during this time. The outcomes were really good. SGMB 96 actually even looked at a phase 2 study of window topotecan, which did not actually work. And this study has actually yielded some of the highest outcomes, especially in high-risk neuroblastoma, where it was close to 70%. The subsequent study of SGMB 03 had the same treatment strategy, but the primary aim of the study was actually not the overall outcome. It was to identify molecular prognostic groups, which it identified, and some of them have already been described by Madam. And these prognostic groups were again used to plan the next study, which is SGMB 12, the ongoing study. And the key differences here is that there is this very low risk group where low dose radiation of 15 gray is being given. That's the WINT group. And then there is the SHH group, where following the 4 cycles of 4 weekly chemotherapy, there is also a maintenance chemotherapy with vismodegib, that is the SHH inhibitor, and the very high risk group, where apart from the 4 cycles of chemotherapy, 3 more cycles of chemotherapy with permetrexate and gemcitabine are also given. So this trial is currently ongoing. There's also another highly complicated PNET5 trial, and which is also ongoing, and this has really done a lot of risk stratification based on molecular groups. What is the role of high-dose chemotherapy in high-risk medulloblastoma? That's actually a question that's really still debated. So we know that it has helped maintain the dose intensity in the Senjude SJMB trials. There's also this PNET high-risk +5, which is in very high-risk medulloblastomas done by a French group, which has found, it was only a phase 2 trial, but the outcomes are really good. So I think we need to look out for more results from this group. So outcomes in average risk medulloblastoma are overall between 70 to 85% and 40 to 60% in high-risk medulloblastoma. Chemotherapy drugs which are used across all protocols overlap, but generally the cumulative cisplatin dose is around 300 milligram per meter square. 600 milligram was poorly tolerated. And the cyclophosphamide dose ranges between 12 and 16 milligram per meter square. Another important thing that we need to see is that cyclophosphamide has been found to be a play a crucial role in improving outcomes in children with WINT medulloblastoma. So that's important. We've already heard about how chemotherapy is also given by molecular risk. There is a targeted therapy, very important to know, because it's probably the only targeted therapy which was found to be effective in medulloblastoma, but also it doesn't work so well. The phase 1 and 2 trials and also the trials in relapsed refractory medulloblastoma have not been really that great. I think we can look forward to the results of the SJMB 12 trial. Another really important factor is that in children with it causes premature fusion of epiphysis, so you really can't use it in younger children. So my last part is about recurrent medulloblastoma, which actually does very poorly. They may respond to chemotherapy, but the long-term survival is really very poor. The kind of recurrent medulloblastoma which is worth treating is those who have been really poorly treated in the beginning. So they've either not received radiation or not received chemotherapy. So then at least there's a role of giving those again. Or those who have received only focal radiation or very low dose salvage, very low dose of CSI, they could be potentially re-irradiated as well. So at our center in TMH, we do salvage irradiation in certain selected cases of recurrent medulloblastoma, but the outcomes are still quite poor. So I would strongly encourage all of you to read the ISNO guidelines, which are somewhat old, but they are really very useful, especially to get a summary of the treatment. And also always look out for the late toxicities in childhood brain tumor survivors. And thank you very much. That's all from me.
Thanks, Maya. That's a really, I think, detailed and great overview in a very, very short time. So you covered almost everything there is to know, except infants. So in the interest of time, we'll go straight to the questions will be in the box at the end. So in the interest of time, we'll go straight to Ramya. So she can tell us about infant medulloblastoma. Ramya, please go ahead.
Yes, sir. Thank you, sir. And thank you to Dr. Vasudev and to Dr. Manas for this opportunity to be part of this discussion today. And Chitra ma'am and Maya ma'am have covered very well about everything to do with medulloblastomas. But what I have to focus on, and I know we are over time and I'll keep it short, is to focus on what is different in infant medulloblastomas and how we treat them differently. So as we know, the age, extent of resection, metastatic status, histology and tumor biology is what determines your risk stratification. So age is very important. And as ma'am has mentioned earlier, that now age group of 3 was what the cutoff was to define infant medulloblastomas. But now the age group is being pushed even up to 4 and 5 years of age to say that they should be treated as per the infant protocols. And traditionally, ma'am has gone through, Maya ma'am, about resection followed by radiation and chemotherapy. But clearly that is different when it comes to infant medulloblastomas. I just want to mention in this slide about the importance of histology as well when it comes to infants as well, because between classic and desmoplastic nodular, those with extensive nodularity and large cell anaplastic, based on this histology as well, treatment can be determined in the infant who comes with medulloblastoma. So what are the challenges in infants and young children? Mainly, obviously, we know it's a growing brain. It's a brain which is very prone to getting later toxicities. So in general, the prognosis is worse compared to older children, because mainly we cannot use radiotherapy just the way we want in older children. And radiotherapy has a huge role to play in children with medulloblastomas. Definitely increased vulnerability of the immature brain to neurotoxic agents. Radiotherapy, as I mentioned, administered to the developing brain is associated with unacceptable detrimental neurocognitive defects. And this including hampering independence and quality of life in these young children. So I'm actually very prone to treat as much as possible and avoid a relapse. But the more you see patients who are survivors, and the more you realize the morbidity that they have if you have over-treated or if they've received toxic chemotherapy, you realize the importance of survivorship, and you realize the importance of discussions like this where you want to avoid this sort of neurocognitive defects in these survivors. So that is why mainly there are 2 approaches to treat infant medulloblastoma. One is the approach of intraventricular methotrexate along with high-dose methotrexate and other drugs, or the role of high-dose chemotherapy with stem cell rescue. So the high-dose chemotherapy was introduced as an alternative to craniospinal irradiation in young children with embryonal tumors. And we know medulloblastoma comes under the category of embryonal tumors, mainly because these are very chemosensitive tumors. And Maya ma'am just mentioned about chemosensitivity and chemotherapy in these children. These are the general sort of bigger trials in infant medulloblastomas, which we should be aware of. One is the Head Start 3 trial and the ACNS 0334, which is the COG trial. The PBTC and HRMB5 are not, as much talked about, or they're not known as much, but the Head Start 3 and ACNS 0334 is what I will just focus on a little bit. The COG ACNS 0334 trial has looked at the role of high-dose methotrexate in induction chemotherapy. So when we're talking about treatment in infants with medulloblastoma, you're looking at chemotherapy specifically. So you want to give induction chemotherapy and several cycles of chemotherapy, just like you would treat a leukemia or a lymphoma child. So this trial looked at 3 cycles of induction with vincristine, cyclophosphamide, etoposide, and cisplatin. And we know these are pretty much the only drugs which work when it comes to brain tumors. This was followed by 3 cycles of high-dose carboplatin and thiotepa along with stem cell rescue. And this stem cell rescue is always autologous stem cell rescue. It's not allograft, because what is the role of doing an autograft in these children? You want to deliver high-dose chemotherapy, And the high-dose chemotherapy is going to go and kill the medulloblastoma cells. But what is the side effect of the high-dose chemotherapy? It wipes out the stem cells completely, and therefore you need the stem cell rescue just so that the myelosuppression is reversed and the patient can develop normal, WBC platelets and RBCs. So that is the whole concept of doing an autograft. It is completely different to doing an allograft. So you collect the stem cells prior to giving chemotherapy from the patient, cryopreserve it, and then give the high-dose chemotherapy and reintroduce the stem cells. So therefore, it's called ASCR, or autologous stem cell rescue, which helps in recovery from the myelosuppression or the myelosuppression. So they looked at the introduction of high-dose methotrexate in the induction as well, along with the vincristine, cycloid, etoposide, and cisplatin, and they found that with the HDMTX, there were significantly higher response rates and remission rates as compared to those who did not receive high-dose methotrexate. And 28% of survivors in this group did not receive, 28% survivors only received adjuvant radiotherapy for residual disease post-chemotherapy, post-consolidation. The Head Start 3 trial is what most of us in India tend to follow and what most of us have experience with. So Head Start 3 is a very intense induction followed by myeloablative chemotherapy. As I mentioned, this is for children who are less than 4 years of age with newly diagnosed localized medulloblastoma, as well as those who are older with disseminated medulloblastoma or post-operative residual. However, the practical usage has always been for those who are infants or those who are less than 4 years of age. This has an induction phase with the same drugs as I mentioned earlier, along with methotrexate and temozolomide, and 1 cycle of consolidation with high dose of carboplatin, thiotepa, etoposide. Adjuvant radiotherapy here is given only to those children who are more than 6 years of age or those who are less than 6 years with residual disease post-induction. So this is the treatment schema which is followed here. You do surgery, maximal safe resection, followed by induction with alternate cycles of cisplatin, cyclophosphamide, vincristine, etoposide, and high-dose methotrexate. And the other cycle includes cyclophosphamide, vincristine, etoposide, and temozolomide. This is 5 cycles of these, followed by second look surgery if required. If not, you do myeloablative chemotherapy with thiotepa, etoposide, and carboplatin. I'll come a little bit to this in the next few slides, followed by plus or minus radiotherapy. The outcome, overall survival in this trial has been about 62%. And specifically, the desmoplastic nodular medulloblastoma has had excellent survival of almost 89%. Followed by the large cell anaplastic and followed by the classic MB. So if you have a child with desmoplastic nodular medulloblastoma is an infant, we can definitely try and see if we can give them this sort of treatment, although there are expenses and there are other side effects which we need to counsel family for, because they do well. These children actually do well and are survivors. So Head Start 4 is under investigation, where they're looking at a low-risk MB arm, where they're decreasing induction from 5 cycles to 3 cycles, followed by 1 consolidation of high-dose chemotherapy. The Pediatric Brain Tumor Consortium is looking at, or has done a study where they have added vernostat and isotretinoin to the high-dose chemotherapy backbone in children with embryonal tumors, which include medulloblastoma as well. And here, the paper has not been published and the results have not been published as yet, but there's an abstract where they have they have reported overall survival of almost 77% in this. Head Start protocols are not without toxicity, and these are babies, these are infants, and you're giving such toxic chemotherapy, so that is something to watch for. They are not easy to do. The rate of toxic death, which was reported by the Head Start 1 and 2 experience, was almost 14%, which is really high. 2% has then been reported by Head Start 3. So obviously you learn more, you do more, and you predict side effects better. And more recent trials have decreased the toxicity to almost 0 to 6%. The main toxicity to watch out for is myelosuppression, electrolyte abnormalities, and infection. Of course, if there's myelosuppression, there is infection. Ototoxicity has been a major concern in these trials. The HDC strategies aim to protect the neurocognition in children because you want to avoid radiotherapy. However, because it indirectly affects intellectual ability and social development by significantly impairing the hearing function, because you're using such high doses and significant amounts of cisplatin. So there are caveats to this as well, and this is something to monitor. Other toxicities in the HCC approach include neurocognitive outcome, which it's a growing brain, and you are giving drugs like cisplatin, thiotepa, which are all very high dose neurotoxic drugs. Nephrotoxicity, neurocognitive outcomes need to be watched for, and second malignancies, because we're using a lot of alkylators like etoposide and the cyclophosphamide, and you're using etoposide as well. The intraventricular methotrexate approach is the other approach for infants with medulloblastoma. These are the HIT SKK trials. The initial trial was in 87, followed by 92, and there's a 2000 trial which is published recently. They aim to reduce the poor neuropsychological outcome of children with CSI and with high-dose chemotherapy. And this includes intraventricular chemotherapy of methotrexate, which is given of a total 36 doses, and along with 6 months of intensive chemotherapy, including the same drugs as I mentioned, cyclophosphamide, vincristine, methotrexate, carboplatin, and etoposide. And this treatment was completed without radiotherapy or additional chemotherapy in the trial that they had performed. Here again, they have reported very good overall survival of 80%. Again, mesoplastic nodular variants had 90% and above survival in this group. Local radiotherapy, however, has been introduced in this group after Jan 2006, especially in those who don't have the desmoplastic nodular variants, because they found if they omitted radiotherapy in these children, the recurrence rates were quite significantly high. So in this protocol, for all children more than 18 months of age, they do, without the desmoplastic nodular, they do include radiotherapy. However, when we say we want to avoid radiotherapy, there is now an emerging role of radiotherapy early itself, especially in embryonal tumors. May not be as much in medulloblastomas in general, but in ETMRs and other embryonal tumors, we know that early radiotherapy does help and should not be delayed. And even in medulloblastomas, probably times are changing. We have to watch this space, especially with the introduction of proton therapy, which has potentially has the potential of decreasing late side effects. The role of radiotherapy will probably be increasing in the future. Now, what are the practical aspects? I'll just take another 1 or 2 minutes to share with you our experience in treating these children. Now, why did we choose between intraventricular and high-dose chemotherapy approach? Simply because in our center, we have more experience with BMTs and in performing high-dose chemotherapy with autografts. And we don't really have as much experience with using an Ommaya reservoir and giving intraventricular methotrexate. And we found this approach to be more practical for us. And therefore, this is what we have used. We had a 1 year, 3 month, we had a 1 year, 3 month old baby girl. She had vomiting, decreased feeding, MRI showed a posterior fossa SOL. Maximal safe resection was done, and there was just like very mild residual which was noted. Medulloblastoma, desmoplastic nodular type. We did the 4-5 induction chemotherapies. However, mind you, these were very difficult. It was almost like doing an AML chemotherapy in this child, especially cycle 1, 3, and 5, which included all of these medicines: cisplatin, cyclophosphamide, vincristine, etoposide, and high-dose methotrexate. She had prolonged neutropenia, myelosuppression, bacteremia, sepsis, and required a lot of supportive care, and not to mention the cost going up simultaneously. She was then taken up for high-dose chemotherapy with autologous stem cell rescue. And this is the protocol that was followed. And I want to confess that thiotepa for 3 days consecutively is something we have never done. And it was associated with significant side effects. We use thiotepa all the time. But this had a lot of adverse effects, a lot of supportive care required. Carboplatin was for 3 days, thiotepa for 3 days, etoposide for 3 days. After 3 days of each of these, she received the peripheral stem cell harvest, which we had collected prior to starting conditioning, along with steroid cover and GCSF from day +5. She had a lot of toxicity. She required all the prophylaxis that we give usually for any transplant, along with specifically N-acetylcysteine, which we use to decrease the risk of VOD or SOS, or veno-occlusive disease, as well as mucositis. And this is our own unit policy where we give N-acetylcysteine as a continuous infusion. She had a lot of loose stools, neutropenic sepsis. She did have sinusoidal obstruction syndrome, but it was mild, so she recovered from it. Grade 4 mucositis, she had engraftment syndrome, as well as cytokine release syndrome, all of this requiring significant supportive care and PICU care as well. We had done an MRI 3 months post-autograft. By then, she was more than 2 years of age. And there was mild residual disease. We did have a debate with whether we should do radiotherapy versus no radiotherapy, and especially because she was desmoplastic nodular variant. But because there was a residual noted, proton therapy was done for this child. However, the doses were de-escalated and adjusted to be low dose CSI plus boost. I don't know the dose levels, I'm sorry, but it was at a lower dose. And mind you, the family had run out of finances by then. The family had completely exhausted because of all the supportive care. However, some way funding was found and proton therapy was then done for this child. We definitely, the same baby, we will have to monitor as we will need to monitor any other child with medulloblastoma, but specifically infants with a growing brain. We need to watch out for neurocognition, endocrine, ophthalmology, hearing, and psychosocial in the future. Thank you.
So thank you, Ramya. So we're a little over time, but I still see almost 100 people waiting. So we'll go through the very few questions. Like, we may skip our speakers' questions and just go down to audience questions. If that's okay with Ramya? You don't mind?
Yes, sir. Yes, sir. Absolutely.
I'm going to
Absolutely.
skip my question. I'm going to skip your question.
Yes, yes.
You can always ask Chitra afterwards. And go straight down to, so Prasant had asked, what's the utility of OTX2 as IHC surrogate? Can it predict LCA histology? So Chitra, you want to field that one?
Yeah, number one, OTX, if you see only for histology, it's positive in classic medulloblastomas, but not in nodular medulloblastomas. So some units use OTX because OTX is used for germ cell tumors. So even departments of pathology not having neuropathology in bulk could have this antibody. So OTX2 can be used to differentiate between the classic and the desmoplastic. Large cell OTX2 is not, I have not come across any review where OTX has helped to identify an LCA histology. For LCA, rather for the synaptophysin positivity, if synaptophysin is being done, people talk about the speckled appearance on synaptophysin, which helps to take out the LCA histology. So if you ask for OTX2, it's histologically. And but for immunohistochemistry, it is positive in Wnt tumors, it's positive in non-Wnt and non-SHH, but it's negative in the SHH, what I mean in these tumors. So in the molecular way, it may help in between the Wnt and the non-Wnt tumors. But if you ask for the histology, it's more in classic, but not in non-classic.
Great. I think that's really helpful. And Anuj Singh had posted in resource limited scenario. This goes to you, Ramya. Like, what is the role of moderately intensive protocols, especially if you have patients with desmoplastic nodular or MBEN, where they're going to have a relatively good outcome? So, like, do you need to take many of those patients to autologous, or can you get by with moderately intensive baby brain protocols? What are your thoughts?
Yes, so I mean, we have used baby brain as well earlier, and they were not less toxic. These children required a lot of blood products, a lot of febrile neutropenia following the same baby brain. And we gave the child for almost 12 months, I think, no, almost 12 months, we gave this baby brain protocol, by which time he was 3 years old, and then radiotherapy was done for the baby, for the boy, for the child. So they are not less toxic. However, it's not an autograft, but they are equally toxic and require significant supportive care as well, even for the baby brain. Which is better? Honestly, I don't know the answer for that. I don't know which is better. But the CEG, the baby brain, is also associated with toxicity, and that baby also required a lot of supportive care. Blood products, every time after CEG, he required blood products. He required febrile neutropenia admissions. So they also did require supportive care.
Right. Point taken. I see Maya hands up. Is your hand up to add something to that, or?
Yes. No, because I think we just recently analyzed our data, because this is what we use. Generally, we use the baby brain protocol. We are not able to cater to our patients with autologous stem cell transplant. So we recently analyzed our data, and we had around over 50 patients with medulloblastoma and around 42 patients, and the 3-year event-free survival was around 50%, and the overall survival was around 60%. But like Ramya says, they do get radiation long-term toxicities. There were a couple of sepsis deaths, and there is substantial toxicity even during treatment. But it is a completely possible protocol when you are unable to give autologous stem cell transplant. It's a very compromised kind of treatment.
Okay, there are probably a lot more questions on this topic, but I think we're really out of time at this point. So I'm not going to, I don't see anything else posted question-wise. Like, but I do see Manas has put down next session, membrane disorders by Dr. Mohandas Narla, not to be missed, 27th June. So there's a reminder for all of us. And yes, the debate of intraventricular versus this goes on. I don't think there's an easy reply to that or response as to which is better, which is worse. Infants in general, I'm just very happy if I don't have infant medulloblastoma to treat. That's the best I could say. So a big thank you, a big shout out to all the speakers, to Ramya and Chitra and Maya. Many, many thanks for taking time out and giving us a wonderful and detailed exposition, and to Vasudev and to Manas for helping to oversee this. And at this point, I think we'll take our leave. Anything else to be added, Manas?
I want to thank the ECO platform as well for providing support for the session. And there is a feedback form which Manisha has shared in the group. So I request everybody to please share the feedback of the session. And thank you everyone for joining, and especially the eminent speakers and the moderator for taking your time out.
And thank you, Vasudev, for getting all of us together. So thank you so much. Thank you, everyone.
Yeah, thanks.
Manas, thank you, Vasudev, and thanks to the moderator and to all the speakers and the audience for giving me this opportunity. Thank you so much.
Thank you, everyone.